Hello guys, I'm Aditya Grover, third year medical resident, here to talk to you about abdominal pain. A very common complaint you're going to hear overnight. Our objectives are going to be to know when is a patient stable, when are they unstable. 2, know when to call for help, not to be afraid to call for help. And 3, how to use our anatomic guideline here to help lead your workup and your differential diagnosis. When you're called for abdominal pain overnight on any patient, it's imperative to know what the vital signs are. Is the patient now hypotensive? Are they tachycardic? Are they hypoxic? Are they febrile? Are they confused? If this is the case, you want to let your senior know because this patient may need to be transferred to a higher level of care, like the MICU. If that's not the case and the patient is more stable, you can run down this really quick anatomic diagram here to figure out what the etiology of the abdominal pain may be. Left upper quadrant, let's start with pancreatitis. Pancreatitis can be more so epigastric with left upper quadrant component. Usually it goes straight to the back. These patients may have nausea and vomiting as well. For pancreatitis, you need to meet 2 of 3 diagnostic criteria. The first is pain typical of pancreatitis, epigastric pain with back radiation. 2, you want to have the amylase or lipase greater than or equal to 3 times the upper limit of normal for that lab reference range. And 3, imaging evidence. A CAT scan that's consistent with the diagnosis. These patients should be NPO and be given aggressive fluids if they can tolerate it. Monitor the vitals of these patients very closely. They decompensate pretty quick at times and may need to be transferred to the ICU. In patients who are diabetic, they may present with nausea, vomiting, left upper quadrant abdominal pain, epigastric pain, acid reflux type symptoms, and this could all be referred from an acute MI. If you suspect that in a patient, get an EKG. If you see changes consistent with active ischemia, you want to let your senior know and call the cardiologist overnight. These patients may need to be transferred to the CCU, may need to be started on heparin, clopidogrel, aspirin, or other medications per. In the left lower quadrant, you have diverticulitis. These patients will have left lower quadrant pain, diarrhea, and imaging evidence consistent with diverticulitis. Antibiotics are imperative in this case. If they can tolerate orals, you can give ciprofloxacin or metronidazole. And if they can't tolerate orals, you want to do IV antibiotics. So the same, cipro, metronidazole. You can do piptazo as well. If these patients have hyperacute pain, some rebound tenderness, some guarding, consider a perforation. If that's the case, you want to get a 3 series immediately. That will look for free air on the diaphragm in an upright position. You want to get the surgeons involved in this case as well. Mesenteric ischemia can also be in the left lower quadrant. These patients can have propensity to clot, whether it's AFib, hypercoagulable state, malignancy, or if it's post-hypotension. Post-hypotension, you're going to have ischemia in the watershed sigmoid region. These patients can have hematochezia as well. If that's the case, you want to get an H&H to look for bleeding and the degree of bleeding. We also have a video on GI bleed, which you could refer to for that as well. These patients might want to get an ABG and lactate to look for ischemia. You should get the surgeons involved as well in this case. Small bowel obstructions can be epigastric. These can be preceded by nausea and vomiting that's progressive and abdominal distension. These patients may have a reason to have obstruction as well, whether it's adhesions from surgery or a mass effect from malignancy. Make these patients NPO and put an NG tube to intermittent wall suction. A KUB initially is a great choice because it gives you a good idea of the bowel gas pattern if you can't get the CT done in time. Although the CT is a better modality. these patients should undergo serial abdominal exams, a surgical evaluation, and any stat imaging if you're concerned for new rebound, if they're obtunded, and you're concerned for a perforation. Acute appendicitis can be localized to the right lower quadrant. It can also start periumbilical initially and then localize to the right lower quadrant. These patients will have fever, leukocytosis, and abdominal pain. Although a CAT scan is great to view the appendix, initially ultrasound may be more effective. In that case, this patient should be on broad antibiotics. Pip/Tazo is a good choice, and a surgical evaluation for management. Right upper quadrant here, you have acute hepatitis. There are a multitude of etiologies for this. It can be infectious with the acute hepatitis viruses. It could be toxin-mediated by ingestion of Tylenol overdose or alpha toxin. It could be post-hypotensive. These patients have been profoundly hypotensive and they have shock liver. They'll have ASTs and ALTs in the thousands. They'll have an elevated bilirubin, and you want to always measure their synthetic function with an INR. If that INR starts to go up, they can be an acute liver failure, and in that case, you want to have a GI or hepatology evaluation. You want to alert your senior, and you want to send this patient to the MICU for closer monitoring. Cholecystitis localizes to right upper quadrant in these patients. You're going to have nausea and vomiting, and a Murphy sign will be present on exam, although it's not very sensitive. Ultrasound will be effective in visualizing the gallbladder to look for any inflammation acutely, although CAT scan is a preferred modality for this. You want to get a surgical evaluation for this patient for any management and start them on Pip/Tazo antibiotics. Ascending cholangitis is what we call a medical emergency. These patients will be very ill appearing, hypotensive, febrile, maybe confused, maybe icteric. You want to put these patients on broad-spectrum antibiotics with meropenem or ertapenem. For that, an ID consult will be recommended. You want to have your senior alert for this as well. These may need to be escalated to the MICU. And you want to also get a GI evaluation for any endoscopic intervention necessary for these patients. So this is a good framework for how to deal with stable abdominal pain. Again, you want to assess if the patient is stable or unstable. If they're unstable, you want to alert your senior and also other consultants on the case. If they're stable, you have more time to go through this anatomic breakdown.